Hi, followers of Neuro Takeaway. As you know, we are committed to keep high standards in selecting our guests, and today is no exception. We have another outstanding neuroradiologist, Professor Gilberto Gonzalez. Professor Gonzalez is the chief of the Division of Neuroradiology at the Massachusetts General Hospital, and he's also a professor of radiology at Harvard Medical School. He is a must figure when speaking about stroke imaging. He has a bright mind that does not always follow the mainstream. So without more delays, I would like to go directly to the interview. Hi, Jill. How are you doing?
Very good, thank you. Great to see you, Carlos. Felicidades.
You speak a little bit of Spanish, I know.
Un poco.
Well, thank you very much for accepting the invitation. It's a real pleasure to have you here. My first question is, after so many years of being the chief of neurology of the MGH, like 25 years, what do you think this institution has in particular that makes it still be one of the top of the list hospitals in the world?
Yeah, well, it's got a very long history. I think it's a combination of things. It's the people that make the hospital really great, but why do we have such a great collection of people? And I think it's a complex answer. It relates to history and the environment that we're embedded. We're part of Harvard Medical School, and but Harvard Medical School, there's 16 hospitals affiliated with Harvard Medical School. So there's all these hospitals, but we're at the center. We're the oldest and biggest hospital. There's also a series of universities, MIT, Harvard University. So there is an environment in Boston. The biomedical environment in Boston is unlike anything else in the world. You know, there may be more research at NIH, but they don't have our hospitals. The combination of basic research, translational research, and clinical research and clinical care is really unmatched. This hospital in particular really prides itself on caring for patients, and it will use everything that's available, even if it's new or experimental, to take care of the individual patient. It's that culture. So it's a very special place. We have a long history. I mean, the New England Journal of Medicine started here, all these things. It attracts the very best people from around the country and around the world. People from all over the world come to work here. And because of that, it sustains itself. It has a momentum that hasn't stopped at all. And so it will continue to be a leader in medicine, without a doubt.
It is rated the second hospital in the US right now.
Well, some years we're one, some years we're two. We all know we're number one, regardless of what the polls say.
Okay. Well, speaking about a stroke that I know is your favorite issue, why do you think it took such a long time to put in practice the treatment of acute stroke?
Yes, it has taken a long time. It took 20 years. We started doing interventional thrombectomy, thrombolysis back in 1995. Back when I started as chief, we were able. We had the interventional team, but we also had the imaging. We were the first hospital to have diffusion in the emergency room. We're the first hospital to use CT perfusion in the emergency room. So we had all this information, and we have very close relationships with neurology, and so because of that, it was a good environment for us to develop the stroke here. Now, back in the 90s and even the 2000s, we didn't get paid for doing stroke intervention. It's something we did, and because we thought we were making things better for our patients, and so we did it. me and members of the interventional team went all over the country and in the world trying to encourage everybody to do this, because we could see that we were having important effects. We were helping a lot of patients. I mean, it was really quite remarkable, the results we were getting. But people wouldn't do it because they weren't getting paid. This is America, and if you're not getting paid, people think, well, then it's probably no good, you know. So it took a while before we actually had the proper prospective trials that turned out to be positive before it was generally agreed that thrombectomy is effective for patients with large vessel occlusions, and you're going to get paid for it. So now my concern is there's too much thrombectomy. I don't think everyone who has an occlusion needs to be treated. I think you should treat the right patient. Not every patient, the right patient. And so I'm spending a lot of my time now saying, wait, not everyone, por favor, por favor.
You cover a very large area around Boston, no?
So yeah, we cover a large area, but there's a lot of hospitals here. In the state of Massachusetts, there's 7 centers. In Boston, there's 5 centers that do thrombectomy. So, 10 years ago, we were the only ones doing all the stroke. Now everybody's doing it, so our numbers have been reduced. That's fine. That's okay.
A direct question. When it comes to assessing the stroke in the emergency room, CT or MR, what do you prefer?
Yeah, well, no, the data, and if you look at the multi-center trials, the Hermes analysis, it's very clear. If you have access to MRI, your patients are going to do better by a factor of 2. That's not here. That's Hermes. That's multi-center trials. When they combine the data and they compare patient selection with MR with patient selection with CT, there's a huge difference. And, well, let me go to one of my slides.
Yes, sure.
So, can I share the screen? Do you see it?
No.
Let's see. How do I share screen? Hold on.
Apparently, I allowed you to share.
Here we go. Here we go. I'm going to do that right now. Okay. So you're going to see a slide. Yeah. This is a paper published by Campbell from Australia, who's done a lot of great work. And it's penumbral imaging and outcomes in patients. This is the Hermes trial. So there was like 7 trials, 1,500 patients. Well, in that paper, they actually compared outcomes in patients who were selected with diffusion compared to patients selected with MRI. Okay, so the top patients here are perfusion, people treated, people that had standard therapy. Down here is diffusion, and this is the people treated, and this is the standard therapy. Okay, you can see the good outcomes here is much better on patients with diffusion. And the other thing that's important to note is the people that had poor outcome, many people had worse outcomes. So anyway, this is the odds ratio. If you select somebody by CTP versus diffusion weighted image, the odds ratio of a good outcome is half of DWI. So that's the bottom line. This is not from our center. That's out in the real world. Okay, and so it's really quite clear that it's. Oh boy, I'm getting called here.
No problem.
Excuse me.
Yes, no problem.
Okay, so anyway, this is from the Hermes trial. If you use diffusion to select your patients are gonna do better, a factor of 2, twice better. The odds ratio are 2, and the reason is because it's a more precise measure. Okay, it's just more precise. It's a measurement. What you want to do when you select someone to treat, you want someone who has a small core, because you're not going to make the core any smaller, but it can get bigger. But if you select somebody who's too big, the core is too big, then you may treat them, but they may not benefit at all. That would be futile thrombectomy. In fact, you might even make things worse. The difference, the thing with diffusion is that it's very precise, within 10% of the true core. The problem with perfusion, and we did perfusion for many years, over a dozen years. We were the first hospital to do perfusion. And I tried to replace diffusion with perfusion, but when we looked at our data, the error in the measurement is very high. It's around 50 milliliters is the 95% confidence limits. So what that means is if you do a CTP and you measure it and you come up with 50, it could be 50, but it could also be 100, or it could be close to 0. That's how big the error is. And when you have lack of precision, you're going to have poor outcomes. And so that's the result.
And so what do you think the guidelines recommends the CT at the first approach to stroke?
So the guidelines are they're based on the trials. And what they say is if you select patients, actually all you really need is CTA. Relative to not treating patients, if you just have occlusions and you don't see an abnormality, you're going to do better than just getting TPA or just standard medical therapy. That was Mr. Clean. So that's that's good. That's better. It's better than not doing anything at all. So the only issue is you may treat people. You will treat people that shouldn't be treated. That's it. That's the main thing. You can't just using the CTP and seeing an occlusion. You will treat people that already have a very large infarct. So it's mostly the futile. You're going to be including people that are futile. So some people say, well, who cares? I treated them. Actually, a lot of people think that. Who cares? I treat them, and if they don't get better, too bad. That's all right. No, it's not all right. This is a very expensive therapy. And think about somebody who has a dominant hemisphere. You might keep them alive, but they can't move, they can't talk. They're miserable. They can't tell you that they don't want to live. Their family's miserable for years. Society is doing things. So all these things, there's a lot of repercussions to having a very poor outcome despite a therapy. So I'm not saying you shouldn't treat these people, but before you do it, you should tell the family member, this is a very large infarct. We may be able to save his life or her life, but it's very unlikely that this patient is it's very likely that this patient is going to need care every day for the rest of his life and may be unhappy. They should at least have the option. And with CTP, I don't think you have enough. It's so inaccurate that you don't that you're not going to be able to do that. With CTP also, sometimes you see a big core, that's not a big core. So some patients you're not going to treat. You think it's a big, the ghost that some have said.
Yes,
the lack of
about the ghost. We all know about the ghost CTP course. If can diffusion weighted imaging course be reversible too?
So the ghost is an artifact, a measurement error. Okay, it's just the wrong. You're trying to measure something that it's not measuring. Diffusion is measuring the state of the brain tissue. Perfusion is measuring the perfusion. It's the vascularity. It's the blood flow there, and those are not the same things. Now, reduced blood flow does cause the infarct, but you're not seeing it. So. And because of that, that's why there's lack of precision. Now with diffusion, is it reversible? Well, it depends on which animal and what time, okay? With a rat, after 10 minutes of a complete occlusion, it's not reversible. In monkeys, it takes 3 hours. In humans, we don't know for sure, but it's probably around 4 hours, more or less. So if you have an occlusion, severe ischemia for 4 hours, it's not going to reverse. Now, it might reverse a little bit in the edges. So instead of a 60 milliliter infarct and you treat it, it might be 58 milliliters. I mean, it's at the edges where there actually is some flow, some collateral flow, that might be preserved, but that's not reversible. Now, people often see cases. This is what the endovascular people from around the world like to say. Here's a big infarct. I saw it on DWI. I treated. I did another DWI, and it's gone.
Yeah.
Yeah, it's gone. I cured it.
Common
No.
story.
Yeah, no. What they have to do then is do a follow-up 1 week later. This is known in rats and in monkeys. So see, diffusion is a physiologic measure, okay? And when you have severe ischemia, there is reduction in the diffusion of water. It's a physiological event, okay? But that's what occurs physiologically. But there's also, at the same time, there's severe cellular injury that's not reversible. So immediately when you have reperfusion, the diffusion comes normalizes physiologically, but the cell is dead. And if you come back a week later, 2 days with rats, the infarct comes back.
Good point.
So it always comes back. So is it reversible? Sure. Of course it's reversible. If it's early enough, it's reversible, less than 4 hours or less than 3 hours. But after that, it really isn't. It may look reversible, but if you do a follow-up image, you'll see that it comes back, always.
Interesting. I have a question about thrombectomy, because you know there are many people that are proposing to do thrombectomy to everybody at the beginning. No, is thrombectomy harmful? Can be harmful?
Yes. I think it's harmful in some people. Someone with large completed infarcts, I think it's harmful. I think the bigger problem that I've already talked about is the futility. This is a big event, and that's causing harm because it costs a lot of money, a lot of resources to do a thrombectomy, and if it's not going to help the patient, I think it's very hard to justify. So that I think is the bigger problem. And you may help someone who, you know, you're not helping them at all if they're very severely injured and they're going to have a life. I mean, you know, let's say someone who has a large MCA stroke, you know, 125 milliliters of the left hemisphere. They're paralyzed. They can't talk. They can't talk, okay? And they have to be cared for every day for the rest of their lives. Is that life? You know, that's a philosophical thing. But if it was me, if I have a stroke, I've already told my interventionalist here, if I have a stroke, make sure you get diffusion. And if I have a big DWI lesion, leave me alone. I don't want to live under those circumstances. Now, some people may, but at least you should be able to tell people, we can do this, and that's what we do here. We've always done that. Even when we have diffusion, we say it's already a very large completed infarct. We can try. If you want us to remove the clot, we will. It might improve the probability of living, but they're going to be very, very disabled for the rest of their lives. Not 100%, but very high probability. And then they can make the decision. Sometimes they say, let them go. Sometimes they say, do everything you want, everything you care. But I think it's incumbent upon us to give the choice to the patient and their family, a true choice, not treat everybody.
You know, there are some people that are questioning the utility of current scales as NIH stroke scale or the aspect scale, because they think that they are kind of insensitive to the evaluation of strokes. What do you think about that?
So there's two things. Aspects is an it's a scale based on the non-contrast head CT. It has marginal value. I think if you see a large completed infarct on non-contrast CT, if you say it's a large part of the middle cerebral artery, I think that conveys the information. It's equivalent to an aspects of 6. You know, I don't think it adds that much information. The NIH stroke scale, though, I think is very important. The NIH stroke scale tells you the part of the brain. how eloquent the threatened part of the brain is, okay? So if you have an NIH stroke scale of 20 or greater, that's a very severe disability. That's a functional disability. They can't talk, they can't move. It's a true measure of what the brain will, or what the body will be if you can't preserve that part of the brain. It gives you a good picture of how bad the disability is if you cannot reverse it. Okay, so that's really critical information. Then you look at the core and you say, does the core explain this big disability? If it doesn't, that means you can reverse the functional disability. If the core is big, then you can say, this is a very severe stroke. These are the symptoms. The symptoms are likely to be persistent. So the NIH stroke scale is actually very important because it tells us about the eloquence of the brain that's being threatened by the ischemia.
Do you use the aspects score on the daily basis, your team?
No. So, no, we don't. So we have, well, actually we do. We say greater than 6 or less than 6. It's
Okay.
big or small. You know. So here's the problem. It goes 6, 7, 8, 9. I have my fellow down in the emergency room. They're real busy, and they come in. Well, what's the aspect score? Is it 7 or is it 5? That's nuts. Here's the hypodensity. And if they say 7, the next day they're going to say, well, no, it was actually a 5. It's meaningless. So we would say it's big or small. That's basically it.
I wonder what will be the role of a diagnostic neuroradiologist in the near future with this upcoming era of one-stop shop approach of stroke. What do you think?
What do you mean by one-stop shop? You mean that there's
yes, the patient goes directly to the suite room, and they, with the flat panel, they do the CT perfusion. So what will we do?
Okay, here we go. So, want me to be cynical about this, or do you want me? First, I'll be cynical, and I'll do. They're going to do it anyway because they're going to get paid for it. They're going to do it, whether they use us or not. They're going to do it. So, the question is going to be, how do you optimize care for patients? And I think the big opportunity that's really not fully recognized is that it's the patients that are far away from the hospital that are most likely that are the largest potential largest number of potential patients are far away from the hospital. In this country, over half of the people in the United States are 6 to 10 hours away from a stroke hospital. Those people get strokes at the same rate as the rest of the population. And those people are the ones that is the great opportunity to help. Now, what people don't understand, they don't recognize, but they will at some point, is that actually most people, when they have an occlusion of a large vessel, they'll have a very fast growth of the infarct over the first couple of hours, but then it stabilizes for many hours, for 24 hours, maybe even longer, 48 hours. And so these are the slow progressors that I talk about. And I think that's half of the population. So this is controversial, but I've got data and from other centers again. So this is, how do you deal with these patients? Well, these patients are not the ones you want to send straight to the angio suite. I mean, they're already 5 hours away. They've traveled 5 hours, so you don't want to put them straight in. You've got time. If this person still has good collaterals, that's what it means. If you have good collaterals, you have a small core, you want to know that before you take them to the angio suite. Then you take them to the angio suite, and they'll do it anyway because they're going to get paid. They're going to do it another one. Yeah, that's fine. But at least they'll know that it's worthwhile.
We will be useful for the delay patients, I think.
So yeah, and it's so yeah, I'm actually coming down to patients that come into the hospital immediately within the first 4 or 5 hours. Those patients, I think you should do a CT scan, at least a CT scan, just to rule out a hemorrhage.
Yeah.
I mean, the majority of those patients are going to have small cores. The data shows it. Probably 70, 80%. Under 5 hours, 4 hours, 70, 80% of those are going to have a small core. I think you should do a CTA to see if it's worthwhile going to the angio suite. But if you do with a CT and CTA, that's probably enough at this point. And you see good collaterals. You can see collaterals on CTA.
Yeah.
If you see good collaterals, you got an occlusion into the suite. If you want to do another flat panel, fine. If you're going to get paid for it, fine. But those people need to be treated. So I don't think you need to go beyond that. I don't think you need to do a special core. However, if the collaterals look terrible, if there's no collateral circulation, then you need to do something else. That's when you need a second study, and then you might as well do diffusion. So, but the early patients, they can go in. If they want to skip the CT scanner, I can't stop them, but I don't think that's. I think most places, as we become more educated, and when we see some of the results of our care, of our attempts to care for patients, I think that people will be reasonable and say it's better to have good data than just the easiest data that you can get at the time. But the big, this is what I'm saying now, is that the big opportunity are the people that are far away, people that show up after 6 hours, after 10 hours, after 12 hours, after 16 hours, we can still treat them. And there's a large number of those. And those you need to image properly.
You introduced this interesting concept of slow progressor. It's amazing. How can we recognize at the beginning a person that will be a slow progressor? Is it possible?
Okay, let's take a couple of scenarios. Okay, the first scenario would be someone who's far away, 6 hours away from a good hospital, a hospital that does thrombectomy, but they go to a local hospital that can do CT and CTA, just that. I think that if you identify an occlusion, a large vessel, an MCA or ICA, if you have good collaterals, that is, they're symmetric, they look the same on both sides or very close to the same, the probability that that person can be treated 6 hours later is very high. So that is a slow progressor. The slow progressor that I've defined are those that have small. If you have diffusion, if they have a small core, that's a clear sign of a slow progressor. Let me show you an example. Hold on. Let me share the screen.
Sure.
Yeah. Let me hold on a second. So here's an example of a slow progressor. Okay. So this is a patient came into our hospital, and he was enrolled in a study to see how oxygen can slow down. It's a long story. It's a work I did with Nih Stroke, who's a neurologist here. But there was a bunch of patients that came through who weren't, for one reason or another, were not eligible for TPA, and they were not eligible for thrombectomy. So all we could do was give them oxygen, but we followed them. And so here's one of these patients with an MCA occlusion. He had significant symptoms. You can see the perfusion is really quite large, but the core is small. This is well under our 50 milliliter threshold. This is the same person 6 hours later, 7 hours later, 8 hours later. So the big perfusion defect is there, and there was still an occlusion, but look at very little growth. This is 1 day later. Still the occlusion's there, and the core is still small. So this is what I call a slow progressor. These are patients with large vessel occlusions but have really good, really excellent collateral circulation. And these people can persist for a very, very long time. And our data shows that about half of all the patients in the country, or the world probably, are these types of patients. And that's data that we've gotten from other people. We've published some of this work here in scientific reports, and I've defined slow progressors as patients that that have a core that's less than 50 milliliters at 24 hours. And we looked at our data, and these are the criteria that predict a small core at 24 hours, the infarct growth rate, and core volumes, okay? And these are very, very good criteria. And then we went and looked at the literature to see if these parameters were measured. Initial infarct growth rate based on diffusion was, we found in 5 different publications. And the key number is 4.2, but we saw that the majority, the median, was below 4 on 4 of the 5 studies. So it's really quite common. And these were large numbers, 186, 185, 166. These are large numbers. And this is from all over the world, from Mass General, from Stanford, from Paris. So the point is that these people, these slow progressors, are really, really common. Now, why haven't people seen this before?
Yeah, that's
because they didn't look at it. No one's looked at it. The reason we did it, okay, I mean, when we first saw this 10 years ago, we were testing oxygen. Nih Stroke, who's a neurologist here, senior neurologist, but back when he was a junior neurologist and did work with me on animals, he showed that giving oxygen prevented the growth of infarcts in rats, okay? And so then we took it to humans. And the purpose was to see if we could slow it down. Well, you can see right here, it worked, right? Except that this person didn't get oxygen, this particular person. It turns out that, and we never saw an effect of oxygen because half of the patients didn't grow. But because of that initial rat study, we're the only ones that have done this study on patients that, imaged them when they first got here under 6 hours. 6 hours later, 1 day, 2 days, 3 days. And we did a prospective study, NIH funded, and we found that this was very common. Over half of our patients were slow progressors. By the way, I should mention that this was the hardest paper I've ever had to get published. Nobody believed this data, nobody.
50% of the population is amazing.
It is amazing, that's why they wouldn't believe it. But that's the data we got, and looking at other people's data, let me see, stop share. So looking at other people's data, it's there. The initial growth rate that I just showed you from Stanford study, the Pittsburgh study, the Paris study, and our study, that's very common. But we're the only ones that actually did 6 hours, 12 hours, 18 hours. So there it is.
Maybe we will be able to treat these patients 48 hours after a stroke.
Absolutely. Absolutely. Physiology is brain, not time. Physiology. I published that paper in 2008.
I read it. I agree with you.
So it is. And yeah, I think that there really isn't an endpoint. If you have an occlusion and you still have a small core, you can still be treated. It doesn't matter when.
Is there any possibility, any likelihood that for this course, this slow progressor course, of come to a halt in their evolution and they don't need treatment?
That's right. So in fact, actually we have good data on that. 50% of patients of the slow progressors, we've looked at them, we've followed these patients, half of them, and none of these were treated, okay? Half of the patients that were slow progressors spontaneously recanalized, and the core didn't grow. Half. The other half did not. Their core did grow over days, okay? So if they did not spontaneously canalize, they got worse. The problem is, on day 1, we could not predict who was going to spontaneously recanalize and who wasn't. So an occluded vessel is deadly. It's a bad disease. And if you don't remove it yourself or somebody else, you're going to do badly. So spontaneous recanalization, great. But if you don't spontaneously recanalize, you're in big trouble.
Okay. You were one of the leaders in the use of perfusion imaging in a stroke. What do you think about perfusion right now?
So yeah, we were the first ones to publish the use of perfusion in acute stroke. This, I think, 1998, AJNR is our first paper on that. And I had great hope for it. I really wanted to replace diffusion. I mean, we had diffusion, but I knew most of the world didn't have diffusion and wouldn't have it for a long time. So I wanted to replace it. So we had high hopes. And so we used it for a dozen years until 2010. But in 2010, we had a conference here amongst ourselves, neuroradiology, neurology, said, let's look at all our data. And let's see, can we replace diffusion with CTP? How good is it? That was the idea. Do we have enough data now to say can we replace it and under what circumstances? Well, when we went through our data, we realized that in fact, it was very inaccurate. The precision, looking at the core estimate before treatment with the core afterwards, the diffusion was actually very good correlation, but the perfusion was not, okay? There was a lot of error in the measurement. And so we dropped it. We stopped doing perfusion in 2011 because it was unreliable. And it took me a long time to try to figure out why it happened. That was the result. And then I went back and said, why is it so unreliable? First of all, it's not measuring the condition of the tissue. It's got a very poor signal to noise ratio, CTP, and then you're doing multiple processing steps. That adds error. Poor signal to noise ratio and multiple processing steps adds error to your measurement. And so all of that results in lack of precision. So you have a big error bar. And let me show you another slide.
Yes.
We did a formal analysis of
there are different vendors, softwares.
Yeah. So I know. Here, I'll show you some of that. Let me share another screen here. So this was the analysis that was definitive for me, okay? This is called a Bland-Altman graph. You see if you could do CTP over and over and over again, it would average out to the correct answer, but you only can do one measurement. So the question is, what's the 95% confidence limit of that measurement? In other words, if it tells me 50, it's 50 plus or minus what? So we compared a whole bunch of patients. Here's the data. It was published in Stroke. We compared diffusion versus CTP, the core determined by CTP, either by CBF or CBV. We tried both of them. And this is a Bland-Altman analysis. And so this is the 95% confidence limits of the true value of the core. And it's plus 54 and minus 59. Mm-hmm. So you're off plus or minus 50 milliliters. It's useless. It's useless. If you're going to have a threshold of 50 or 70, it's effectively useless. And sometimes you're going to be right. Sometimes you're going to be wrong. But sometimes you're going to treat people that you shouldn't be treating. And sometimes you're going to treat people that you shouldn't be treating. So that's what did it. And this is reflected, and I've already showed you on the Hermes analysis. If you use MR, you're going to get better results, better outcomes in patients because it's more precise. And you see it all the time with people comparing CTP using one product versus, like, this is one patient here who, let's see, the patient was 84 years old, 6 hours after stroke onset. This is processed using one software. The core is too big to treat. This is another software. The core is similar, is small enough to treat. And people show this all the time. And then they try to wave their hands and say, well, that's, you can see, you can figure out which is correct and which is, no, you can't. It's a noisy method. It's a method full of error. So that's why you really can't rely on it. So we came to this conclusion nearly 10 years ago. But since then, we've looked at our data to see if it's had any effect on our outcomes. We have very good outcomes here when we use diffusion, and there was no effect at all. We eliminated CTP, no effect on how many patients we intervened on, and no effect on the outcome of the patients, absolutely nothing. But what would we do? We saved patients radiation, we saved contrast, we saved time. It was a waste of time.
Let's move to another point. I know that you are working on artificial intelligence in MGH, in the MG Brigham Center for Clinical Data Science. I don't know if you can share with us the advances that you've made so far, but if you can give us some sneak peeks of
Yeah.
this, it would be nice.
Okay, I have some slides. Yeah, so we're working on with a commercial partner on the development of a suite of algorithms for acute stroke. Uh, Analysis of the non-contrast CT to see if there's hemorrhage or not. Analysis of the non-contrast CT to see how big the core infarct is. Detection of large vessel occlusion, just like Viz.AI, a perfusion analysis, and then a diffusion analysis. So we're developing all of these. We have all this data here, and so we're developing all these algorithms, and they're all complete now. But the one I'm most excited about is the non-contrast CT one, and I'd like to share that data. I have it over here. So. Did I share it? Are you see?
No?
Can you see the slide? No, not yet.
Not yet.
Let me share the screen.
Now, yes.
Now you're seeing it. Okay, so these are the algorithms we're developing. But the one I want to talk about is looking at acute infarct, because this I find very fascinating. Oh God. So what do these CTs? These are all CT scans with people with stroke. Okay, and
Yes.
so there's so all of these patients. So all these patients, I'm sorry, I'm having trouble with my slides. So I'm going to just end the show and show it to you without. So these are all patients right here that have occlusions, and they all have strokes. On this one, you can see the stroke very easily.
Yeah.
On this one, you can barely see it, some loss of gray white matter. This one's very subtle, and this one you can't see at all. But all these patients also had MR. And on diffusion, you can clearly see the strokes on all of them. So what we did was we took over 4,000 patients. You know, we've been doing stroke and CT on thousands of patients. So we took 4,000 patients, and we had the computer. We told the computer to try to predict the diffusion abnormality based on the DWI, and there was over 4,000 patients that we looked at, and then we tested it. We tested on a set of patients, and so this is the results of the predicted volume on non-contrast CT versus the true volume on DWI, and you can see that there's very, very good correlation.
Amazing.
It's amazing, yeah. And
we do.
And this is what really knocked my socks off. You know, for strokes that are greater than 50 milliliters, almost 90% sensitivity, almost 100% specificity. Okay, for strokes that are greater than 20 milliliters, 80% of strokes bigger than 20 milliliters were seen by the AI. Okay, and virtually no false positives. Okay, it's only the little tiny ones that it missed. So this AI method is actually better than humans. For this group right here, the best human data is on the order of 60% sensitivity, and we're already at 80%. So this is very exciting. So, so here's an example of four patients. The ground truth based on DWI is in red. The predicted volume on the non-contrast CT is in green, and the overlap is in yellow. And you can see it's really remarkable how close it is to the true value. So this is the one algorithm that has really impressed me as being able to do something that we can't do as humans. It's picking something up in the image that's too subtle for us to see. And so there I see as advantage. The other algorithms they're no better than humans. The advantage there is that you don't need a human, so if a CTA is done, somewhere in nowhere land, it can be automatically analyzed and with a high probability can tell you the right answer. Not 100%, but
Just
this here, that is for everybody everywhere. So there's a great future for artificial intelligence.
It's amazing. What about COVID-19? What's your experience with that in relation with the stroke? We've read about large vessel strokes. We read about thrombotic microangiopathy. What's your experience?
Yeah, we've had a local experience. In patients that are in the intensive care unit that have gone on to MRI, the most common abnormality is microthrombi and microhemorrhages. That is, it's 70% of our patients have micro. So you need diffusion, you need susceptibility weighted image or gradient echo to pick it up. So that's the most common. After that, we see strokes. We see microstrokes, little tiny ones, but we also see large vessel occlusions, but that's a minority, less than 20% of those that we've seen here. Finally, there's a third group that I'm not entirely sure how big it is because we're probably not imaging them enough, that produces a very profound leukoencephalopathy. So it's diffuse white matter disease. We catch it early, and it's associated with diffusion, reduced diffusivity. So it's a diffusion abnormality, but it involves large areas of white matter disease. I think that's a hypoxic event, lung, because they can't breathe well. They're not oxygenating their brain enough, and they get this, what we think is a hypoxic leukoencephalopathy. So those are the three patterns we see in the brain. Microangiopathy or microthrombi, microhemorrhages, occlusions with acute strokes, large vessel occlusions and medium size. And the third one is leukoencephalopathy, hypoxic leukoencephalopathy. The numbers, we don't know. Before when the virus first came through our hospital, we were only doing CTs and we weren't seeing anything. Once we started doing MR, we started to see a lot of abnormalities. Now there's been some publications that suggest up to 50% of patients that get hospitalized will have some, well, for sure. This came out of Spain. There's a good study that's just published in Neurology out of Spain, that out of 700 patients, over half of those patients who were hospitalized had neurological symptoms. Now, how many of those had abnormalities on the brain? That's detectable on MR, we don't know, but it's a large number. This is a very bad disease that really affects the brain.
And what do you think these microangiopathy mean?
Yeah, so we're learning about that. The virus infects the endothelial cells, and when it infects the endothelial cells, it causes the endothelial cell to come away from the basement membrane. Exposure of the basement membrane causes thrombosis. It's a prothrombotic process. And so D-dimer goes way up. It's a coagulopathy.
Okay.
And it happens in other parts of the body, but it happens in the brain.
Okay. Well, we are reaching the end of the interview. Some years ago, I visited MGH, and you showed me the ether dome, the famous ether dome. And what does it mean to give a conference there now?
Oh, it's a great honor. I've had the privilege of giving a few lectures there, grand rounds in neurosurgery and neurology, and there's I've been given conferences all over the world and under very prestigious circumstances, but it's the greatest honor I think I've had is actually to give a lecture in the Ether Dome. It's a really wonderful place. It's an old place. It's still the same, pretty much the same as it was 150 years ago when the first patient was given anesthesia. That's the Ether Dome. They gave ether while they did a surgery, and it's still the same. It's a wonderful place. It's a huge honor. People that come visit there, I go at least once a week to see, well, I used to before the pandemic, to go see lectures there. And
it's quite a small place.
it's very small. Yeah, it's an old surgical theater, and it's high up with the lights and stuff. It's just a wonderful place. I'm glad you got to see it. I'm glad I took you there.
Well, the last question, but very important. I would like to know, what advice would you give to a young neuroradiologist that is fascinated by stroke imaging?
Yeah. So what I would say is keep up your interest, because we're still at the very earliest stage. You know, I've been doing it for 20 years, but we have a long ways to go. We're learning more and more about the physiology. We're learning more about the various clinical manifestations, and we're learning more on how to best optimize patients. And we're learning that there's a huge population that needs to be treated, that's potentially treatable. For all these reasons, we need neuroradiologists to help out in the organization of the entire process. I think there's going to be great tools with artificial intelligence, with teleradiology, but you need someone who really understands the fundamentals of the imaging and what physiologic information the imaging provides to properly organize a system, and also assess individual patients, and then continuously improve the process. So I still think it's a huge area of tremendous opportunity, and I want to encourage whoever's interested in going into it. I've been doing it for 25 years now, and there's still a lot to do.
Well, Jill, we run out of time, unfortunately, because I could stay all day talking about the stroke with you. So thank you for being here in our channel. Our followers will be delighted with this conference, I'm sure. Thank you very much.
Gracias a ti, y fue un gran placer hablar contigo por esos minutos.
Bueno.
Hasta luego.
Bye bye. Thank you.